initiative for the infectious disease and primary care workforces in the state of Maryland. For more information, please go to www.alivemaryland.org. Next slide, please. Services that we offer are individualized trainings and technical assistance, CME-eligible virtual trainings and self-paced curricula, downloadable resources and toolkits for community partners, and an interactive MDH training calendar. Next slide. SEBA and training core content areas include HIV, viral hepatitis, STI prevention and treatment programs, health equity, financial management, prevention and surveillance, and so much more. Next slide. The target audience intended for this training are physicians, pharmacists, nurses, PAs, psychologists, social workers, and other healthcare providers engaged in the care of patients with HIV. Joint accreditation statement in support of improving patient care. This activity has been planned and implemented by the Postgraduate Institute of Medicine and Health HIV. Postgraduate Institute for Medicine is jointly accredited by the Accreditation Council for Continuing Medical Education, the Accreditation Council for Pharmacy Education, and the American Nurses Credentialing Center to provide continuing education for the healthcare team. Continuing education that is available for this training is for physicians, nurses, pharmacists, physician assistants, social workers, and is also available for psychologists and the interprofessional continuing education credits. Next slide. A disclosure is that this activity may contain discussion of published and/or investigational uses of agents that are not indicated by the FDA. Planners of this activity do not recommend the use of any agent outside of the labeled indications. The opinions expressed in the educational activity are those of the faculty and do not necessarily represent the views of the planners. Next slide. Participants have implied responsibility to use the newly acquired information to enhance patient outcomes and their own professional development. The information presented in this activity is not meant to serve as a guideline for patient management. Any procedures, medications, or other courses of diagnosis or treatment discussed or suggested in this activity should not be used by clinicians without evaluation of their patients' conditions and possible contraindications and/or dangers in use. Next slide. Credit is available, 1 credit hour for the completion of this activity. You will receive a link via email to the site to be able to claim your credit. Next slide. And the speaker has nothing to disclose. Next slide. Now I'd love to introduce our faculty member. Dr. Andrew Tatarski has worked with people who struggle with drugs in their families for over 40 years. Andrew developed integrative harm reduction psychotherapy, or IHRP, for treating the spectrum of risky and addictive behavior as an alternative to traditional abstinence-only substance use treatment. He is the founder and director of the Center for Optimal Living in NYC, a treatment, education, and professional training center based on IHRP. Andrew has trained individuals and organizations in 19 countries. His writing, teaching, clinical work, and leadership aim to promote a rehumanized view of problematic substance use and a harm reduction continuum of care that will extend help to everyone who needs and wants it wherever they are ready to begin their positive change journeys. Welcome, Dr. Tatarski.
Thank you so much, Shannon, for inviting me to present, and thank Alive Maryland as well. And I want to also thank the participants for joining us today. Actually, this is the second of 2 presentations on IHRP. In the first one, we talked about the realities, the kind of clinical challenges that people who struggle with drugs bring into our clinical practices. And then we talked about these dominant I would say, negative or problematic narratives about people that use drugs or struggle with drugs, disease, moral weakness, stigma, and criminal views of folks. And that those dominant narratives have given rise to an abstinence-only approach to treatment that has been very, very limited and problematic, and I think has really contributed to our failure to be of help to the majority of people that struggle with drugs. You know, we then talked about an alternative model, what has been called a psychobiosocial framework. That is a model for understanding the entire spectrum of substance use as really reflecting this complex interaction of psychology, biology, social context, relationships, you know, what's happening in the world around us. And from this point of view, we might think of what we call addiction as an experience and a set of behaviors that are really meaningful responses to suffering. And this is a complex process that helps us understand why people may continue to engage in these behaviors in spite of negative consequences and risks. It also, I think, provides a real theoretical foundation for why I believe that a harm reduction framework to frame helping relationships is really essential as a context for engaging, offering people relevant and effective interventions to support them in making positive change. And I am one of, a group of people that have applied the harm reduction framework to psychotherapy, substance use treatment, mental health care more generally. And my model I call integrative harm reduction psychotherapy, because I think if we think of a multiple factors that's really contributing to this complex syndrome, we need to be able to integrate and draw on many different interventions that will address psyche, the body, relationships, and social context in a way that is really tailored to the uniqueness of each individual in a unique social environment. And so in the first session, I presented all of this material as background and support and overview and introduced IHRP. Today, we're going to go through the 7 therapeutic tasks, which is sort of my way of modeling, mapping, the major things that we're trying to do when we're helping people that are struggling with problematic drug use and other risky and problematic behaviors. So we're going to go through the 7 tasks and really highlight rationale, specific techniques and strategies, some of which you may be able to begin using immediately in your practices. Next slide, please. So the first task, of course, is creating therapeutic alliance, engagement. And I think creating safety is a way to think about that. And particularly when we're thinking about how we engage and work with a group of people that frequently have histories of personal trauma. There's lots of research that really supports the idea that the overwhelming majority of people that struggle with problematic drug use have experienced developmental trauma or major traumas in their lives that are kind of at the core of their relationship to drugs. And then in a stigmatizing, criminalizing, punitive society, many people who use drugs have experienced trauma as a result of their drug use. So trauma is really at the core for most folks. And so our first challenge to think about is how do we create safety with folks that come into helping relationships with expectations of being hurt, being punished, being kicked out of treatment, which is frequently what people have experienced. So the therapeutic alliance is really the foundation upon which everything else that we can do with folks sits. And so it's the primary focus initially, and I think throughout the treatment. Now here's a primary definition of how we create strong therapeutic alliances. Safran and Moran did a major study of therapeutic alliance literature, and they found that the strength of the alliance is based on an agreement about goals, tasks, and the quality of the bond. So this is really our challenge as helping professionals, to come into agreement with folks. And here's where I think the harm reduction tenet, that we meet people where they are rather than where we think they need to be, is so critical to coming into agreements with patients about what's relevant to them in terms of their goals and, you know, coming up with an approach to positive change. So, of course, we need to begin by getting the patient's definition of the problem and their reason for coming. Very often in traditional treatment, the substance-using person comes into treatment and they're told what the nature of their problem is and what they need to do to get help. And that frequently is really at odds with the patient's experience. So we need to really start where the patient is in terms of what brings them, how they view their issues, and then we can offer them something that really speaks to what's relevant to them. Then we need to reflect an understanding and empathy to make sure that we're actually hearing folks. And then I think of checking in. You know, am I on target here? Did I get it right? Are we on the same page? You know, when the patient can say, yeah, I feel understood and heard, we're in alliance, right? And that's the basis for, you know, moving forward in our work. Next slide, please. Now, what I've attempted to do is really operationalize that and think about a whole range of engagement skills that really put that harm reduction tenet of starting where the client is, starting where the person is, into a very specific set of recommendations. The first one I think of as an invitation, right? How can I be of help to you? This really sends the message that this helping work is about the client, right? And it's about what's relevant and important to the client. You know, then what we get to do is use our skills as listeners to listen empathically, right? To try to really get the client's experience, emotional experience, the content of their experience. So I think about empathic harm reduction listening and resonance as the primary thing that we are doing when we're engaging folks. Then we can engage in a collaborative inquiry. We invite the client to be curious with us, to kind of deepen the understanding. And then we get to reflect empathically. You know, this is what I think I'm hearing you say. This is what I think I'm hearing at a feeling level in terms of content. And then we check in, as I said, do we get it right? Now, what is so crucial to this process is managing our reactions, or what we call technically in therapy speak, our countertransference, our subjective experience. Because, you know, we've all grown up in a culture that stigmatizes and criminalizes and has kind of negative presumptions about people that use drugs. And very often those feelings and those reactions get triggered in us, and they can actually derail our ability to listen and to really listen to this unique individual sitting in front of us. So that's really critical to, you know, staying on top of being curious about our reactions, but being able to put them to the side so that we can actually be present with that individual and not act out. These folks tend to be very, very sensitive and very attuned to judgment, to criticism, to negative reactions. And so I think this is such a key part of the engagement process. You know, then we can offer a formulation or a kind of a sense of how we're hearing the issues that the person is presenting. And here's where we can actually reflect empathy in a recognition that drug use is meaningful. It seems to be a reaction to struggles, whether psychiatric, emotional, relational, lifestyle struggles. And we begin to invite the patient to really see their drug use in the context of these complex factors. And that itself can be another important way of creating alliance as we come together around a shared understanding of what the nature of the problem is. That then can lead to meaningful discussions about moving forward. So, for example, if we can identify that drug use seems to be related to anxiety and relationship issues, we can then talk about how addressing the drug use is really going to require a focus on helping folks with anxiety, relationship issues, and so on. Next slide, please. Now, the second task I think of is the relationship as itself an agent of healing. We talked in the first session about how substance use often not only has personal meaning, that is a response to maybe personal struggles and difficult emotions, but it has relational meaning. And what I have in mind is that very frequently, growing up in families, there are certain feelings, there are certain needs, vulnerability, anger, sadness, sexuality, which are punished, which are judged, or which are not even recognized. And so these parts of the self often need to go underground, to be dissociated in order to cope with that particular family. Now, where do those parts, those needs, those aspects of self go? They often go underground, out of awareness, and they may resurface as people discover that drugs and other kind of self-soothing activities can be a way to care for those parts or express them, care for anxiety, care for fear, comfort, difficult emotions, but outside of one's relationships. And to the extent that that's true, folks bring these conflicts, relational conflicts, into current relationships and tend to turn to drugs rather than people. Now, when they come into our helping relationships, as we accept that people will be actively using, we invite people to come into treatment with their active substance use, and then we invite people to be curious about what's living in that relationship to the substance. What parts, what feelings, are you expressing or caring for? And as we can actually help people identify those aspects of self and invite them into our relationship, we actually can create what in therapeutic language we call a corrective emotional or relational experience, where people can have the experience of being safe with their full selves, with their emotions that were not accepted in earlier relationships. And now we can talk about how one might integrate those parts of the self within themselves and within their relationships, which is really a fundamentally important part of helping people kind of let go of the need for the substance. Now that healing relationship then also helps people feel safe about looking at their relationship to substances and beginning to identify what's problematic, what's harmful, right? And then begin to work collaboratively with us to set harm reduction goals or positive change goals that will actually reduce the harm and bring their relationship to substances more in line with their other values and what's important to them. So the relationship really allows the harm reduction relationship that invites people to come in with their active substance use, allows for a reworking of the interpersonal and relational issues that have been expressed through problematic behavior. And so this may be one of the real keys to changing addictive behavior, as people can learn to turn to people rather than to a drug. Next one, please. Now, the third task, enhancing self-regulation, I think is so key, particularly when there's trauma present, but not necessarily. Very often, problems with self-regulation or affect regulation, that is, difficulties sitting with uncomfortable feelings, are at the core of why people may turn to a drug or other self-soothing behavior in an impulsive, addictive fashion. Major theoreticians, Kantian, Crystal, and others have talked about and suggested that self-regulation difficulties are often at the heart of substance misuse. So to the extent that we can actually enhance or support people in enhancing their capacities to self-regulate, self-manage, sit with uncomfortable feelings, contain those feelings. That really can support people in sitting still around those urges to use and creating a space to think about, alternative, healthier, self-affirming responses or ways of caring for oneself. Now, what are some of the things that we can do to enhance self-regulation? Well, curiosity, our genuine curiosity about one's relationship to substances, rather than meeting people with presumptions, with anger, with criticism, or with a presumption of disease, to really invite people to be curious together, I think itself can support the patient, the client's curiosity, which then can bring us into a kind of alliance around what Danielle Stern has called an alliance around compassionate curiosity. We can be curious together, and curiosity actually supports self-reflection, reflecting on, what is this urge to use all about? And mindfulness, which, one of my teachers defined simply as awareness with acceptance. That is, to be aware in the present moment with an acceptance, which is not that I need to like it. I don't necessarily need to like the way I feel or like what's going on. But if I can bring an accepting awareness to what's going on with curiosity, I can then begin to think about how I want to respond to this reality from choice rather than from impulse. So mindfulness is a very powerful tool, really, that can support kind of observing, making connections between sequences. This event happened, I felt this way, I had this thought, then I thought about using, or I thought about responding in a certain way, right? And as people can really identify these sequences, it becomes important or possible to think about how to interrupt those sequences with new responses. We also know from research that mindfulness actually strengthens affect tolerance. That is, simply practicing sitting still with distress increases our capacity to tolerate distress. To name it, to sit with it, to think about it, to contain it. And then it opens up the possibility and strengthens our capacity to make choices that are in line with our values and goals. It also enables us to notice what we might think of as the impermanent quality of our experiences, meaning feelings don't stay there in one place, like a solid object. Feelings shift, feelings change, right? And if we can sit with an urge or a craving, often it just disappears. Think about those of you who are smokers and you've been on an airplane or you've been in a movie, and you've had an urge for a smoke, but you can't smoke. So, you let go of it and the urge passes. So mindfulness can really shift our relationship to urges and cravings. Also slow, deep breathing, slowing down the breath. Herb Benson wrote this wonderful book called The Relaxation Response, in which he talked about how distress is really about a sympathetic nervous system, fight-flight reaction. Slowing down the breath actually activates the parasympathetic relaxation response, and it's a way of turning down the intensity of what we're feeling. So these are some basic skills that we can teach, we can model in our work, and we can teach to support people in developing a strengthened, greater capacity to sit still with an urge. And then that opens up all sorts of possibilities for change. Next slide, please. Waiting for the next slide. I think the next slide is about urge surfing, or this idea that the urge is the axis of change. This occurred to me one day, that every behavior, verbal or physical behavior, begins with an urge. right? And if we can catch that urge before we move into action and sit with that urge, then it becomes possible to think about alternatives. I talked in the first session about how not only is the relationship to the drug meaningful, but over time, when you repeat that meaningful response, I drink, I feel anxious, I have a drink, I feel better. Repeating that hundreds or thousands of times develops what learning and behavioral theorists call overlearned habits. We condition ourselves. And we don't just condition the behavior, having the drink, we condition ourselves to feel urges, very strong, powerful urges, right? Now, if we can sit with that urge, stop the action, interrupt that urge action sequence with urge surfing, a number of things happen. One of the things is that we get better at urge surfing, like it strengthens that muscle. The other thing that happens is that by not acting on the urge with the reinforcing substance, over time, the intensity of that urge diminishes. In AA, they talk about the miracle. Don't give up before the miracle happens. I think the miracle is that if you can hang in there with your urges and not reinforce them with the substance, over time, those urges begin to fade. Now, better yet, if you can respond to the urge with another reinforcing or another rewarding activity that actually helps you feel better, not only are you inhibiting the addictive urge, but you're wiring in a new repertoire, a new way of caring for oneself. And it's through repetition that the change happens. Urge surfing also facilitates reflection. It gives us a space to think and to inquire into the urge. We'll talk in a few minutes about what I call unwrapping the urge, being curious about the urge, what's driving it, what's living in that urge, what aspects of self live there. I talked about a former client of mine yesterday, Valerie, and I hear this many, many, many times with different clients. As we begin to become curious about what's living on the other side of an urge, often there is trauma, or there is very difficult affect, emotional experiences that now we can begin to understand and work with in different ways. So urge surfing can lead to discovery of aspects of the self that are living within that addictive process. And then we can think about new choices, alternative ways of responding. And working in those alternatives is another way to think about the recovery process. Next slide, please. So this is a visual schematic way to think about it. The trigger might be the emotion or the event. We have that urge, and if we can bring that mindful pause, surf that urge with mindful awareness and breath, it interrupts that, and it makes it possible to make new choices. Next, please. So I'd like to invite the group to just take a moment to do a little mindfulness, a very, very simple checking in process, which at my Center for Optimal Living, we often do individually and do in groups with folks just to kind of invite people to really become present in the moment with the group. So we can just pause for a moment and simply acknowledge what's here now. Bring your awareness in to notice body sensations, with acceptance, with curiosity, with kindness. What's the quality of your breath? Just notice the experience without making any changes. As you inhale and expand the chest, as you exhale, feeling yourself settling into the seat that you're sitting on. Notice if you can experience the coolness of the air on your nostrils when you inhale. So we're really simply trying to get out of thinking into actual experiencing what's present in this moment. You might notice the sensations of your feet on the floor, the position of your body in space. How are you feeling right now? Aches, pains, sensations of air on your skin? And what is the quality of your thoughts? Do you notice yourself getting pulled into thought, or is your mind pretty quiet right now? Any emotional tones? How are you feeling right now? So I think about this as really practicing, kind of getting disengaged or disidentified with our normal patterns of thinking and really practicing being present in this moment. The mindfulness practice is such an important skill that supports everything else that we may want to do with folks that promotes positive change. Next slide, please. So now we can bring that mindfulness to the urges, right? So if you can imagine your own urges or imagine the urges of your clients or your loved ones, imagine that you could observe or witness a craving or an urge without reacting to it, simply noticing the urge as it arises in your body. Notice body sensations associated with that urge. Where in your body does it arise? It is in your chest, in your mouth, your face, in your heart, in your stomach. Does it stay in one place? Does it move around? Are there any emotions, thoughts, feelings, reactions associated with this experience? Just see what happens if you sort of sit with that urge, with curiosity, with acceptance, slowing down the breath. And you might imagine that the breath is like a surfboard, surfing over the waves of that urge. And you're just hanging out with it, right? Putting a little pause around it. And just like real surfing, if you practice this, you get better at it. So I'll tell clients, let's say you're not ready to make any behavioral changes. You're not ready to think about changing your relationship to substances or other risky behaviors. Are you up for practicing urge surfing? You might do it for 5 seconds. And then, you can always do the thing. So from a harm reduction perspective, we want to empower people to make their own choices, their healthiest choices. Urge surfing actually helps support people in getting in the driver's seat of their urges and their decision making. Next slide, please. Now, we've hopefully got a good relationship. We have a good alliance. We've got a client with us who's got some increasing skills for sitting still with distress and with difficult emotions. Now we can engage in the fourth task, which is what I think of as assessment as treatment. Another major contributor to harm reduction therapy, Pat Denning, really coined this term. And I think it's a wonderful term to speak to assessment, not just as what we do in the initial phase of treatment, but throughout our work together. We're deepening, through urge surfing and unwrapping the urge, we're deepening our understanding of what's driving or what's living in this problematic behavior. And as we make sense of and untangle, the multiple meanings, the psychobiosocial factors, we can then fine-tune and really shift the focus of our treatment together, And I think this is what happens in any healthcare, right? We sort of deepen our assessment over time, and then we can kind of collaborate with the client in coming up with interventions that really speak to them as unique individuals. So our ongoing assessment facilitates the client's self-assessment. And also, I think it builds curiosity. The microanalysis is one of the techniques that we may use. And this is really a way of looking at and applying mindfulness to the pattern of substance use or other risky behavior in a very fine-tuned way. So I may ask people to describe, the pattern of use in the previous week or month. What is that typical pattern of use? And how does substance use fit into other aspects of your life? Right? So people may note that, when they're in certain circumstances, out with family or friends for dinner, they're very much in control of their drinking. But when they're alone on a business trip, or when their family goes away, or, then they find themselves overwhelmed by urges to engage in really problematic behavior. So this is really a way of helping people begin to make the connection that the pattern of use and what's problematic about it actually is intimately tied into feelings, relationships, life circumstances, and begin to make those connections. Another really valuable question is, what do you want from your substances, and how did it work out? People often have certain expectations of these behaviors that are based on either previous experience or just kind of social ideas about, substances that actually are not accurate. And so helping people bring a really sensitized awareness to, what the actual impact of the substance is can really help people, burst those misunderstandings or mistaken assumptions about the substance use. And of course, we also want to help focus on the problem severity. What are the negative consequences? And when do they happen? Under what circumstances? What behaviors contribute to those negative circumstances or consequences? Next slide, please. So I mentioned this other very important, I think, assessment technique. No, back, please. What I call unwrapping the urge. So if, we've now empowered the individual to develop the capacity to sit still with that urge. Now, if we're presuming that the urge is actually meaningful, that it's laden with meaning, it's not just the leading edge of the brain disease idea. Of course, the urge may be related to, dopamine depletion, etc. But that's one among, I think, many components, and much more, I think, relevant is the meaning that the urge is expressing. So I want to invite a dialogue with that urge, and invite the client to begin to become curious. And here are some of the questions. So as you're surfing your urges, participants, you might reflect on the urge and begin to ask a question. What was happening just before the urge kicked up? Is there some meaningful connection there? Or can you connect with what that urge wants? What does it want to change? If the urge could speak, what might it say? Is there a story that the urge has to tell? Is there a part of you that is living within that urge? With Valerie, as I asked her this question, she looked a little stunned and she said, "Oh, it's the traumatized part of me," which then led to a whole exploration of a history of multiple traumas. Next slide, please. Now, to the extent that the relationship to substances is actually expressing something or resolving something or satisfying something that is meaningful, that is important, that is vital to one's psychic survival in many cases, it makes sense that people would be highly ambivalent about giving these behaviors up in spite of negative consequences or risks associated with them. So when we shift from disease to meaning, ambivalence becomes a very important stumbling block to change, as opposed to the old idea of denial that I think was very much associated with an older disease concept. So to the extent that ambivalence is generally present, with Valerie, she was highly ambivalent because the substance was actually her substance. Injecting an powerful prescription opioid was really helping her manage trauma symptoms and also helping her express a dissociated part of herself that could get expressed around the drug use. So it's very important to invite the ambivalence into the room. In traditional treatment, often, we only want to speak to the part that wants to change. but then the part that wants to continue using is left out. In this work, we want to invite both sides of the ambivalence in. It's a very powerful motivational technique, because if we can actually invite people to sit with their ambivalence, not in battle, which is how people generally experience their ambivalence, but in dialogue, then there's a kind of tension. If the substance is helping me with my anxiety, and yet it's putting what's important to me at risk, my health, my family, etc., that can motivate a kind of inquiry or conversation about how else might I meet the needs that the substance is meeting in a way that will be more in sync with my other values. And that's where sitting with ambivalence can actually lead to what we call harm reduction goal setting. So it's important for us to observe and make an alliance with both sides of the ambivalence, non-judgmentally, rather than siding with one. What we want to side with is the part of the person that wants to kind of resolve this in a healthier way, or a way that's more in sync with one's values. Next slide. So splitting ambivalence is something that many people understand. It can be a painful state. If I split off the part of me that wants to stop, then I'm just left with the part that wants to use, right? So getting a constructive dialogue, helping people experience ambivalence, allows this consideration of new goals. And it also allows people to develop this experience of being integrated. I want to do this thing, and yet I don't want to do this thing for all of these reasons. And that also can help strengthen people's ability to tolerate ambivalence, so that people can think about choices rather than, as I said earlier, act on impulse. Next slide, please. So here are some techniques. We need to empathize with both sides. We can actually speak to the voices of both sides. Chair work. Motivational interviewing is a technique that very much embraces ambivalence. And there's something called the decisional balance, which is a more systematic way of getting at this. Next slide, please. Here's the decisional balance. It's a wonderful systematic way to gather lots and lots of information about the current pattern and the new pattern that's being considered. Each pattern has benefits and costs. The current pattern is benefiting people in certain ways that we need to understand if we're going to be having a conversation about new ways to respond. And there are costs, right? The problematic consequences and risks. The new pattern also has benefits, hopefully, but it also has costs. So what this will help us understand is the benefits of the current pattern, the costs of the change are going to be obstacles to change, which we're going to need to address in our treatment planning. The costs of the current pattern, the benefits of the change are going to be motivators. So I will often have people come up with a positive motivation checklist, really, to carry in their pockets so that they can pull it out when they feel the urge and can kind of go through it, which is why I've decided not to act on this urge and engage in this new pattern of behavior. Next slide, please. And as I said, when we're sitting with ambivalence, we can now think about harm reduction goal setting. That is, consider alternative choices for the part that wants to use that are more in accord with the part that wants to change. And here we're really supporting people's choice, agency, motivation. The question of what are your goals really helps empower people, puts them in the driver's seat. It promotes curiosity. It also increases retention, right? This is about you and your goals rather than me imposing my goals on you. And finally, another piece of the harm reduction model that I think is so important is small incremental changes, like what goals are realistic to experiment with right now, rather than expecting quantum change, like a shift from where you are to abstinence, can just feel totally overwhelming, as opposed to what are you up to experimenting with today, this evening, right? And let's experiment with new goals and see how it works out. And what do we learn from them? Next slide, please. Finally, the seventh task. Now that we've got some good goals, we can now work on strategizing together for how can we get from here to those goals. We might think about long-term goals, but also, as I was suggesting, what's realistic for today or for this week. And one of the techniques that we love is what we call the optimal use plan. It's a strategy for really inviting people to think through, how would I ideally want substances in my life, that would maximize the benefit, minimize the cost. That's a provocative question, but it really invites people to think about, how am I doing with my substances? What's working? What's not working? What do I want to change, right? And we might ask people to think about subjective goals, like I don't want to feel stupid, sloppy. I don't want to feel ashamed and embarrassed. I want to be in control. But then the objective goals, how would you change your actual substance use pattern to bring it more in line with those subjective goals or those values? How much? How often? Under what circumstances would you be using? What else would you have to change in your life? Now we're talking about the other issues that may be driving the problematic drug use or maybe contributing to the problematic drug use. So this can be a plan that can be a work in progress. Folks go out and try it out, see how it goes, bring it back into sessions. We can then strategize together about what worked, what didn't work, and then we can begin fine-tuning the plan over time. Another neat idea that is related to this is what we might think of as the game plan. For every circumstance where you might be challenged, if you go into that circumstance with a game plan, that is having thought it through beforehand, thought about your goals, thought about the challenges, come up with some strategies for meeting those challenges, you're going to increase your chances of success. So next slide, please. Finally, and then we'll have a little time for Q&A, about 10 minutes. I really like to sort of suggest to clients that part of this process is very much about learning better skills, right? Driving, skiing, swimming, and sometimes substance use can all be potentially lethal activities. So we don't necessarily ask people who are bad drivers or skiers or swimmers, to stop. Sometimes we do. But in many cases, we really need to take a good hard look at, the problematic behavior. If you've had several, bad driving accidents, we're going to want to really understand, what was going on for you there, right? What contributed to that? But here are some analogous ideas that can be very useful to clients. If you're going to be driving, you want to know what your destination is. Where do you want to go? What's your intention? What are your goals? The route is analogous to strategy. How are you going to get there if you don't have really a thought through strategy and plan? And then what are your skills? Good defensive driving skills are like self-management skills, curiosity, mindfulness, affect, acceptance, emotional acceptance and tolerance. And then all sorts of harm reduction strategies. Do you know about risk? And are you taking precautions to reduce risk, etc. So next slide. And I think we're on to, these are just some takeaways that I'd like folks to think about. Harm reduction saves lives, no doubt about it. The research supports that statement, 1,000%. I think we need to embrace a rehumanized view of people who use and misuse drugs. Harm reduction is an essential part of effective helping. We need a harm reduction continuum of care that engages the entire spectrum of folks, people who are actively using and people who really want to stop and are committed to abstinence. the harm reduction umbrella and enables us to engage people across that entire spectrum. Integrative harm reduction helping is going to address this whole unique, complex human being, their mind, body, spirit, relationships, life circumstances. And I would invite you all to become a harm reductionist and be part of the solution. If you're really interested in further training, you should go to centerforoptimalliving.com. We have lots of training activities and webinars. We're having a free webinar series coming up very soon, beginning in October, that will go into applications of harm reduction therapy across many populations and modalities. So thanks so much for joining us. And Shannon, I know that there are some questions and comments that maybe we can dialogue about.
Yeah, and before we, thank you for that. It was wonderful. Before we get into the question and answer, I just want to remind everybody that we have another harm reduction webinar tomorrow on wound care and injection drug use with Barbara Piper. And next slide, please. And also save the date. Alive Maryland will be holding a Harm Reduction Innovation Virtual Summit on November 9th. 2022, and details will be coming soon. If anybody has questions, go ahead and put them in the chat. I know Judith asked if there are resources in place that can assist individuals dealing with deaf and other physical disabilities that struggle with substance disorder and would benefit from the harm reduction tools.
Well, you know, I didn't really talk about this, but our Center for Optimal Living is really, in New York City, is a home and a platform for offering these services and making them available across the country to the extent that we can support individuals and organizations in incorporating this. And, you know, this is a very exciting sea change moment in our field where more and more organizations and clinicians are becoming interested in and open to incorporating a harm reduction framework into their services. So there are a number of explicit harm reduction therapy centers around the country, and a lot of individuals that are beginning to embrace this. So people can reach out to me at the Center for Optimal Living at my email address, and to the extent that I'm connected to resources around the country and around the world, you know, I'm very glad to support people in connecting to those resources.
Justine asked, what experience have you had with brief harm reduction psychotherapy? I'm thinking of people who are incarcerated or experience homelessness.
Well, that's a really, really interesting question because, you know, particularly where there is trauma or very difficult social circumstances and, you know, emotional challenges, you know, the work can be very, very long and very complex. And I talked in the first session about, you know, when we shift from this disease concept to this psychobiosocial framework, where we're really understanding that there's a lot that may be going on contributing to the problems, I suggested that we need a social revolution, or we need a change, a macro change, to really make this kind of work available to more and more folks in an affordable way. But we have to live within the realities, right? So in each of our short-term services, if somebody's in prison, if somebody is in a short-term, you know, a psychotherapy center or a treatment center that can only offer time-limited services, I think there's a lot that can be done, you know, setting the stage for later work. So helping people, you know, have a positive experience of a clinician who's actually open to, in an empathic way, helping them to understand why, something about the nature of their drug use and why they've gotten into trouble. That is, doing that initial work of engagement, creating safety, offering somebody some self-management skills and some initial notion of, the meaningfulness of their use can actually be highly valuable and motivating then to engage in a next kind of level of treatment when they leave that circumstance. So, I think, for example, in residential care, that might be 2 weeks or 30 days or 90 days. There's only so much that can happen. But if that could be the focus, then that could be a really valuable springboard for next steps in care.
Are there any more questions? Could you talk about some of the successes experienced by Portugal?
Oh, well, that's a really interesting question. I don't know if this questioner knows that I recently was invited to Portugal. My first in-person training, since the pandemic. So just 2 months ago, I was in Portugal training a wonderful organization there called Vitae in this work. I had been there about 2.5 years ago, just before the pandemic, because the International Harm Reduction Conference was in Porto, Portugal, and I met with a number of people, so I know quite a bit about it. The thing about Portugal is that they decriminalized drugs about 30 years ago. And, one of the important findings or the data of decriminalization is that injection drug use went down, overdose levels went down, and more people went into treatment voluntarily. So that's an argument for decriminalizing all drugs. And I think that, we haven't yet really gotten to a serious discussion of that here in the States, but I think it's time. Unfortunately, the treatment system in Portugal is not so advanced. So there's this disconnect, which we see often in many places where harm reduction is really advanced as a public health intervention, which is hugely important, what we can do to help people stay alive and healthy, with clean syringes, with safe injection sites, with overdose prevention, et cetera. But there's still a lot of traditional abstinence-based disease model thinking in Portugal. So the treatment system is in transition in Portugal in a way that it is in the United States right now. I think that, we're in a position where there are tremendous progressive changes happening across the United States, but there's still a lot of old school thinking and a lot of change to be done. But there are a lot of wonderful folks that are working in Portugal and other places to bring about this change.
And we have one more question. How do you address the stigma within a center by staff that do not agree with or understand harm reduction?
Well, education. I think education, I talked in the first session about this paradigm shift, this model shift, and the reason that I think about it like that is that I think a lot of resistance to harm reduction is based on misinformation or old models, old thinking, old paradigms. A paradigm is a way to connect the data, right? And when you come up with a paradigm, a model that better explains the data, I think people are more prone to embrace it. Like, oh, that makes sense, right? So I think that rather than battling with our colleagues that are not accepting harm reduction, we need to meet them as harm reductionists, meet them where they're at, engage in meaningful dialogues, and then really invite them to think about, the data of how old school abstinence-based treatment has not been helpful to the majority of people that struggle. The data or the theory about how we might understand that, and theories like this psychobiosocial model that better explain the clinical phenomenon, and then how that really sets the stage for a theoretical foundation that supports a harm reduction approach. And then we have lots of psychotherapy and treatment understanding that also supports a harm reduction framework, like what I talked about at the beginning today about the psychotherapy research on therapeutic alliance completely supports a harm reduction approach. Education, and not battling, but engaging in meaningful dialogue with people.
Thank you, Dr. Tatarsky. This was great. This is wonderful. Thank you, everyone, for coming. We will be sending out an email with all your continuing education information and slide deck. And please be sure to fill out our evaluation form, because your feedback is very important to us. Thank you.
Thank you, Shannon. Yeah. Thank you so much.